The topic today is diabetes emergencies, and in particular, we are going to focus on DKA, hyperosmolar non-ketotic state, and we will say a couple of words about hypoglycemia. As I said, I'll try to, keep it relatively short. Unfortunately, I don't see you, but I know you can ask questions through Zoom. I would really be happy to answer any of your questions. And I wish I could see your faces, but it is what it is, especially right now with the Omicron, looming over us, coming with vengeance. Okay. So the diabetic ketoacidosis and hyperglycemic hyperosmolar state used to be called HONC. Now we refer to it as a HHS. Those are both truly life-threatening emergencies. And I know some of you think the endocrinologist has no emergencies. We do have some, not too many, and those are probably the two most important. On this slide, I just put, distinction between two conditions in terms of the most important features, such as blood glucose value, pH, bicarb level, presence of ketones, and anion gap. Sometimes those conditions, it's very obvious whether you're dealing with DKA or HHS, but sometimes it's a little more subtle, and it may appear that patient even have feature of both, so it's not always a clear cut. Again, HHS typically has very high glucose levels, more than 500-600, up to 1,000. The DKA glucose is typically over 250, and I say typically because this is a big caveat. Do not assume the patient doesn't have DKA if the glucose is less than 250, if they meet all the other criteria. Glucose can be very deceiving. The pH is very important. In the DKA, it's going to be less than 7.3. HHS typically has normal pH, and then bicarb level, of course, will be low in DKA, not necessarily in HHS. Presence of ketones, characteristic of DKA, rarely in HHS, except that, remember, the ketones in the urine often can be due to starvation. And now that everybody is on this keto diet, which is very popular, people that are truly, adhering to keto diet, they will have every morning, if they check their urine ketones, they'll be positive for ketones. So the urine ketones itself are not specific. It's really serum ketones that we have to go by. And of course, the anion gap is going to be present in DKA, while in HHS, you're going to have the high serum ASM, typically more than 320. So those are really the main distinguishing feature between two conditions. So what is the cause of DKA? It's an absolute or near absolute insulin deficiency. So again, patient goes into DKA because there is no insulin, which then results in hyperglycemia, ketone body production, and systemic acidosis. In HHS, there could be some insulin deficiency that then causes hyperglycemia. And because of profound hyperglycemia, we have hyperosmolarity, significant loss of water, dehydration, but no ketone production or acidosis, as we already said. The DKA most commonly seen in type 1, but can be seen in type 2. We'll talk more about that. HHS is going to be in type 2 diabetics or previously unrecognized diabetics. So what is again, the pathophysiology of DKA? Well, due to unchecked gluconeogenesis, we have hyperglycemia, osmotic diuresis results in dehydration, unchecked ketogenesis will lead to ketosis, and anion gap formation. And again, why do we have all of this? It's the lack of insulin. So the main driving force, always remember, is lack of insulin. So if you see the patient in DKA and they tell you, yes, I took my insulin, highly suspicious. Highly suspicious. Typically, when you dig deeper, it will be patient that has not taken insulin or taken significantly less than what they are supposed to do, of course, with other precipitating factors. Okay, so the insulin deficiency is the key, and what I just said, kind of now in the more graphic form. I like this diagram, but basically it tells you that due to insulin deficiency, you have hyperglycemia, which of course then leads to hyperosmolarity, glycosuria, through the loss of glucose in the kidney, and then insulin deficiency because it leads to breakdown of fatty acids, lipolysis, increase in free fatty production, which then forms the ketones and cause acidosis. And it's ultimately really the main thing that causes the cardiovascular collapse and endangers the patient is the acidosis, as well as the shock or severe dehydration. Okay, so the HHS, we said it's similar. However, there primarily you have high glucose leading to dehydration, often seen in patients with renal failure, insufficient insulin for prevention of hyperglycemia, but sufficient to suppress lipolysis and ketogenesis. Okay, and therefore there is usually no acidosis with HHS. There is often precipitating factor for both conditions, including the infections, myocardial infarction, or any type of illness. So one more time, both the DKA and HHS have a lot of overlapping symptoms. DKA exclusively for type 1 diabetics and younger patients, almost exclusively. I shouldn't say exclusively because there are exceptions. As I said, I'll talk more about that. But typically type 1, HHS, older type 2, and then volume depletion present in both, much bigger in HHS. Both can have electrolyte disturbance, but DKA will have acidosis. HHS is not going to have acidosis. Okay, so who are the ketosis-prone diabetic groups? So we already established autoimmune type 1 diabetes characterized by absolute insulin deficiency. Your type 1 diabetics cannot live without insulin. How long does it take for type 1 diabetic to go into DKA? That's the question you need to know, not because it's going to be on your exam, but practically if you don't give your type 1 diabetic patient insulin, which sometimes happens, unfortunately, when they come to hospital, they are put only on sliding scale. Patient can go into DKA in as little as 4 to 6 hours. Type 1 diabetic glucose increases on average 40 milligram per deciliter per hour. In 4 to 6 hours, they can be in DKA. Or you have type 1 diabetic, came on insulin pump, patient went straight to the OR, pump was taken off. Now you're seeing patient next morning on the floor. Nurses didn't put the pump back on, nobody wrote the pump order, endocrine was not called. This is all the typical scenarios we see, fortunately not too often. Your patient can be in DKA. There is a type of diabetes called LADA, latent autoimmune diabetes of adults, sometimes referred as a type 1.5 diabetes. Those patients also can go into DKA or they can present with DKA. Type 2 diabetes rarely, unless, really if they are in this category here, which is burnout type 2. What does that mean? Well, the type 2 diabetics, they start with certain amount of insulin in their beta cells, but with time, they use that up and eventually they may run out of insulin. And when they run out of insulin, sometimes we refer to them as a functional type 1. So the type 2 that has run out of insulin can go into DKA. And also there is this entity called Flatbush diabetes or ketosis-prone diabetes. The Flatbush name after the neighborhood in Brooklyn, New York, where it was first described, more common in African Americans, Hispanics. Typical patient would be the nuanced and type 2 diabetic, overweight, present with DKA. Think of Flatbush diabetes. Okay, so there are some patients that may present with DKA, but they really are not type 1, and so who are those people? As I already mentioned, people like in Flatbush diabetes, more common in minorities. This is often newly diagnosed, and obese. So that's a typical scenario. Family history of type 2 diabetes. The more family members with type 2, the more likely your patient has type 2. Remember, the concordance for monozygotic twins for the type 1 is about 50%, for type 2 is 90%. The higher the number, the more, inherited diseases. So it's actually, type 2 is more inherited than the type 1. The typically patients with negative antibodies, including negative anti-islet cell antibodies, anti-GAD antibodies, they usually goes against type 1 and for type 2. Fasting C-peptide levels, yes, if C-peptide is present, that's a good sign. If it's low, that may be more suspicious of type 1, but C-peptide may be low initially when they present in the hospital. So usually that test should be done in the outpatient setting. Okay, so just to remind us about what is the, normal anion, how is normal anion gap calculated? Again, you know this formula, and what is the normal gap? Normal gap is less than 12. Causes of anion gap acidosis beside DKA, well, there are a lot of other causes. It could be alcohol, could be lactic acidosis due to sepsis, for example. It will look just like DKA, except for the glucose part, the uremia, the overdose, methanol, ethanol, those are often board questions. So just to remind you, there are other causes of metabolic acidosis in addition to the DKA. Oops. Here we go. So what happens in the recovery of you can have the hyperchloremic acidosis during recovery of DKA, and that's due to very, typically we replace those patients with high doses of saline, and due to the large saline infusion, you can have hyperchloremic acidosis, or due to renal loss of bicarb. So the closing of anion gap is the best sign for recovery of DKA, and it's better than actual just correction of acidosis. And you know this, that we can only say that somebody is out of DKA once when the gap is closed. Okay. So what are the ketone bodies? Just to bring you back to medical school, I know we don't have medical students today with us, but there are three main types of ketone bodies. And the ketone bodies that is the, specifically ordered, unless you specifically order the, you may not get the beta hydroxybutyrate, you may only get the acetone and acetoacetate. So the it may sometimes you can miss that. I think right now our lab is actually doing all three of those. Okay, next. Sorry, my computer is having a little difficulty. Here we go. So initially, the beta hydroxybutyrate acid is the most dominant ketone body at the beginning of DKA, and then during the recovery, the balance shifts to acetoacetic acid. So again, it goes back to measuring anion gap and the gap closure rather than following any of those individual ketone bodies. So we already talked about DKA often having a precipitating cause, and yes, the patient, has to, there has to be some degree of insulin deficiency, typically coupled with some underlying cause such as infection, cardiovascular event, myocardial infarction, something else going on in the body. It says missed or disrupted insulin treatment 25%. This is a little bit misleading. This is the data from the up-to-date, but really there has to be some kind of disrupted insulin use. Patients that are taking insulin as directed typically will not go into DKA. You can imagine that if patient is sick, let's say they have the gastrointestinal infection, or now they have respiratory infection and they are not, the appetite is down, they're not feeling like eating. What is the knee-jerk reflex for a lot of diabetics? Well, if they are not eating, they don't take their insulin. If they don't take insulin, and they are type 1 or insulin deficient, the whole DKA cycle can start again. 4 to 6 hours, the earliest, but it may take up to 24 to 48 hours sometimes. The first symptoms they start experiencing: thirst, increased urination, often abdominal pain, nausea, vomiting, weakness. And of course, there are things on physical exam that you can look for. There is this typical shallow breathing called Kussmaul's respiration. If the breath will be fruity, described as a fruity due to the acetone, they may be hypothermic, definitely often tachycardic, and with orthostatic hypotension, dry mucous membranes, all the typical finding of someone seen in dehydration. In HHS, there is even greater severity of dehydration. So again, the common theme in HHS is dehydration, and hyperglycemia much more severe. There could be hypernatremia. I presume that everybody in the audience knows how to correct the serum sodium for the glucose elevation. So if you have a patient with a sodium of 130 but a glucose of 500, that is not hyponatremic patient. And do not try to treat hyponatremia until you correct their glucose. Because some insulin typically is still present in patients that have HHS, again, they are not likely to be ketogenic or acidotic. So now that you already, that we went over that, I put this table here again for you. Sorry, that I think nicely contrasts all the main findings, the laboratory findings that you see in DKA and HHS. And I think if you know this, you pretty much you are not going to miss either condition. This is the algorithm for treatment of DKA from up to date. It's pretty comprehensive. Again, this is something for your home reading. And by the way, I'm happy to give the slides to Chief Resident to distribute if you want to have them. But basically, just a couple of words to mention. So when you are called to see those patients, they are probably, they're always going to be in the ER because they're going to come to emergency room because they're usually significantly sick enough to come to emergency room. And ER would have already given them some saline. I refer to normal saline as an entrance ticket to ER. Every single patient I've ever seen in the ER pretty much has at least 1 liter of saline. And if they stay long enough, they get more than 1 liter. So after the initial saline infusion and the labs confirm DKA, in addition to that, further continuing to address their IV fluids, their fluid status by giving IVs, and of course, choice of IV fluid also will depend whether they are severely, orthostatic, hypotensive, or not. So it may vary from after initial normal saline to be half normal or normal. The main focus then should be on insulin. The patients that are in DKA typically receive a bolus of regular insulin followed by insulin infusion. Well, here are the couple of problems. Again, speaking of 20+ year experience at Georgetown, what happens, the ER may give them an IV bolus of insulin, 5 or 10 units typically, and then they will call medicine team and said, okay, now you're in charge of this patient. And if there is no bed, patient may be hanging in an emergency room for a while. And the medicine team often will order insulin drip, but insulin drip will not start in the emergency room. They usually like patients to be transferred to a floor. And while this is all happening, glucose is still high, patient is still acidotic, and it may be sometimes hours until, the ball starts rolling. The IV insulin has very short half-life. Again, I wish, somebody, and maybe somebody will raise the hand and tell me, So here is the question. What is the half-life of IV insulin? When you give the patient bolus of IV insulin, how long that really lasts in their body? Okay, anybody wants to, you can put the answer in the chat box. Let me see. There is a still,
is it about 15 minutes?
Yes, very good. Somebody said 2 hours. 2 hours is too long. It's about 15 minutes. That is correct. So it's extremely short. Okay, it's a, so you have, that's why you have to follow by the drip. Otherwise, you know, patient will remain hyperglycemic and acidotic. I know we have this new, there's a new DKA insulin protocol in the hospital. It's a little weird for a lack of better words, but it is what it is. Those protocols gets approved by pharmacy department and some committee, which I was not involved, but there are different protocols that are out there. I mean, regardless of what protocol you use, I highly recommend do not count on that protocol, you know, that to be autopilot, meaning just because you have written order for an insulin drip and don't rely that, you know, nurses will just take over and you don't have to check on patient, you know, until the next day. Because each patient is individual and sometimes those protocols don't really fit their profile in terms of insulin sensitivity. Some patients can recover their glucose toxicity and you know, very quickly turn around and the gap may be closed quickly while they may need drip for much longer. And again, you have to be really checking on them. So in addition to monitoring insulin, and we'll talk about switching them, you know, converting them from drip to sub-Q, but just to mention the other, in addition to fluids of insulin, often, you know, the patient may need a potassium replacement, especially if potassium is less than 3.5 or 3.3. So those are all the things that to watch for. Okay. For our patients that are on the, they have HHS, it's similar, but the main emphasis there is fluids. So if the question on the exam is if you are presented the patient and you made the diagnosis that patient has HHS, there is no acidosis, you're confident you're not dealing with DKA, and if you are asked what is the next step in, you know, in treatment for that patient, and if you are offered fluids, insulin, potassium, cortisol, when dealing with HHS, the answer is fluids. Okay, that is the answer. It's not even fluids plus insulin. It's fluids first. After you have adequately hydrated them, then if needed, you start with insulin. But it's remarkable how often the glucose, you know, significantly can decrease just with fluids. Okay, so the big question is when to transition the patient from insulin drip to sub-Q, because you don't want to keep them clearly on drip forever. And nurses are very keen to, you know, for patients to be transitioned while they're on a drip. They need the glucose check every 1 to 2 hours. It's cumbersome for staff. It's, you know, a lot of sticks, finger sticks for patients. So when should you transition them? Well, if you are dealing with DKA patient, you should transition when glucose is typically less than 200, but more importantly, you know, when the gap is closed, the bicarb is more than 15, and you know, the pH is normal, and the key word, the gap is closed. Okay. In HHS, we should stop if the patient is on insulin drip, you can stop the insulin drip where normal osmolality is achieved, patient, you know, is maintaining well. And then clearly one needs to allow some overlap between sub-Q and IV insulin. How long is the overlap? Well, if your patient is eating and you are going to give them a short-acting in addition to long-acting insulin, then you can just do 1 hour overlap. If the patient is not going to eat at that moment and you are just giving them long-acting insulin, for example, glargine, then one should do 2 to 4 hours overlap, at the minimum 2 hours with the long-acting insulin. And speaking of eating, one common problem that we see is you will have somebody that came with DKA, they were, maybe nauseated, they didn't eat initially, but within, let's say, following morning, patient is doing much better, they want breakfast, but the gap is not closed yet. So because gap is not closed yet, you do decide to run still continue running insulin drip. What will happen if the patient is now eating on top of the insulin drip, it's going to cause a lot of, roller coaster with their blood glucose. Because let's say before breakfast, they will be on 2 units of insulin per hour on the drip. Now this wonderful medium consistent carb diet, breakfast comes, that's supposed to have 60 grams of carbs. And 2 hours later, the glucose is 250. Nurse will follow the protocol. It will increase the insulin by a couple of units. And then just before lunchtime, now the glucose will be too low because, the food is gone and now patient is on like sometimes double insulin dose, again, depending on the type of protocol. So the way to deal with this is if the patient really wants to eat and they're still on the drip, give them a small amount of prandial insulin sub-Q. I know sometimes it gets a little confusing for nurses, especially because they think, well, they are on the drip, so that's why do they need additional insulin. The other thing you can do is if you have a patient that you are really not sure how to transition from insulin drip to sub-Q, let's say, sometimes the gap closes very quickly. It's a new onset diabetic. You have no idea about their insulin requirements. What you can do is you can give them a small amount of long-acting insulin. What is the small amount? Well, as little as 0.2 units per kilogram. So if it's a 70-kilo patient, maybe give them between 12 to 15 units of glargine. And then, you continue drip for a little while, and then you will, as that insulin is kicking in, the insulin requirements on the drip will just keep coming down and eventually kind of drip shut itself automatically. So that's another way of doing. So there are many different ways how you can transition those patients, but whatever you do, please do not just stop the drip and then transfer them to the floor and hope that somebody will write some new order. And in the meantime, patient is left uncovered without insulin. So what are some major causes of the morbidity and mortality in DKA patient? Well, it's often, we talk about cardiovascular collapse, shock. They may have impaired renal function, so there is a component of renal failure, respiratory distress syndrome. There is increased risk of thrombosis, especially also in the HHS with the hyperosmolar state, cerebral edema. So there are a lot of potential causes. And of course, we already established a lot of patients will have precipitating illnesses such as MI, stroke, or sepsis, pancreatitis, pneumonia, that will then push them into DKA. So I already discussed some pitfalls, but I'm going to repeat it again. And some of the major pitfalls is, not looking for underlying causes of DKA. Yes, there is often a cause in addition to patients skipping insulin, but often they are sick and that's why they skipped insulin. So you need to find out what is that precipitating illness. Don't forget about potassium. Don't follow serum ketones. Watch the anion gap and look for the anion gap closure. And then stopping the IV insulin too soon. I think I really drilled that hopefully enough. Okay. So I think I already talked about this. Also, what are some common things that we have seen? And this is really from everyday practice with our patients, non-adherence to insulin. Why would patients stop insulin? Maybe because they are feeling sick and not eating, but sometimes patients stop insulin because, you know, a very, very sad reason, but it's happening more and more often. Patient cannot afford insulin. We have patients come to, you know, hospital with DKA because they ran out of insulin and they could not afford to, you know, the refill, or they lost insurance. You know, if you have a psychiatric patient that's also type 1 diabetic, that's a very tricky situation. Insulin errors and pump malfunctioning. Yes, unfortunately, with insulin pump, with all the benefits that pump has, pump only has short-acting insulin. And if there is occlusion in tubing and patient goes to bed and they don't wake up throughout the night, and if they are not connected to continuous glucose monitor, they may wake up next morning in DKA. So that is one risk factor. And I think I already talked about other possible causes. So this was the DKA and HHS. I think we have a couple of more minutes. I want to bring your attention to hypoglycemia. Again, it's something that's seen in a hospital. It's seen in an outpatient setting, and definitely, you know, hypoglycemia and insulin management kind of go hand in hand. But before we go into specifics, let's just, you know, talk about what are some, how do we divide hypoglycemia? Well, hypoglycemia is usually divided into fasting, postprandial, or factitious. Why is it important? Well, it's important because each category may be associated with different conditions. Although, of course, if patient is just simply taking insulin, that can cause both fasting and postprandial hypoglycemia. Factitious hypoglycemia, you know, it's going to be on your boards, anything factitious. Factitious thyroid hormone use, factitious hypoglycemia, it's always, you know, the stereotype of some medical provider that it's either trying to lose weight and taking thyroid hormone, or it's taking insulin for some secondary gain or part of Munchausen syndrome or stuff like that. Okay. Just a reminder, okay, when we talk about hypoglycemia, that we get the terminology correct. So what is the definition of low glucose? Because if you ask patients, you'll get 10,000 different answers. You know, some patients, any glucose less than 150 may be for them low glucose. You know, some patients is less than 100. But medically speaking, when we say hypoglycemia, that is the blood glucose less than 70 milligram per deciliter. We do divide glucose into hypoglycemia into level 1, level 2, and severe hypoglycemia. This is the American Diabetes Association, you know, classification of hypoglycemia. So the level 1, it's less severe, that's between 54 and 70. Level 2 is the clinically significant hypoglycemia when glucose is less than 54, and typically that will be associated for more severe symptoms. And then you have a level 3 or severe hypoglycemia, where, you know, that is when patient has severe impairment and needs the assistance to recover from hypoglycemia. So there is really no given number for that. However, most people will start developing neuroglycopenic symptoms with the glucose of below 50. And definitely when glucose goes below 40, that is when you start, you know, with the loss of consciousness, seizure, and coma. So what are some causes of hypoglycemia in hospitalized patients? Well, the most common, of course, cause is the, you know, use of insulin. And among those patients that use insulin, often it's in a setting of renal insufficiency. So you know, when you have a patient with decreased renal function, that puts them at high risk. And then especially when you have end-stage renal disease patients on insulin, they typically become very brittle, prone to hypoglycemia. Another important category we see often in the hospital is malnutrition. Patients with cancer, they have lost a lot of weight, patients with liver disease, those are typically patients that are prone to hypoglycemia, even without independent of insulin use. Hypoglycemia can be seen as a sign of sepsis, usually as a bad prognostic indicator, can be seen in malignancy. So, and of course, you can see hypoglycemia. Very interesting entity is the hypoglycemia after bariatric surgery. This is typically after big Roux-en-Y procedure, not usually not seen in a sleeve, patients that have sleeve, but your typical Roux-en-Y procedure that will lead to, severe hypoglycemia and sometimes to condition called nesidioblastosis, which is the hypertrophy of the beta cells. And it can become very devastating to the point that patient may need a pancreatectomy because it's so severe. And of course, the most typical cancer associated with hypoglycemia is insulinoma, which is the insulin-producing tumor. We often think of it, but how often we see it, I would say less than once a year we find patients with insulinoma. So it's good to maintain your degree of suspicion, but it's extremely uncommon. Let me just remind you again of symptoms. So the initial symptoms are adrenergic due to activation of sympathetic nervous system, include sweating, anxiety, tremor, nausea, palpitation, tachycardia. Warning here that all those symptoms that I just mentioned, those adrenergic symptoms, can be seen in a panic attack, for example. So adrenergic symptoms are not as specific. However, with more significant hypoglycemia, patients start developing neuroglycopenic symptoms, and those include the headache, visual disturbance, inability to concentrate, confusion, and of course, with more severe loss of consciousness or seizure. So neuroglycopenic symptoms are always much more significant than just adrenergic, but adrenergic symptoms are that initial warning. Of course, if your patient is on beta blocker, which a lot of people are, that may mask some of their adrenergic symptoms. How do we treat hypoglycemia? Well, it depends again on the severity. If it's a mild to moderate and patient is conscious, the oral route is always preferable. That means that giving patient either juice or glucose tablets, and then repeat blood glucose in 15 to 30 minutes. How much juice? Well, one little juice that everybody gets in the hospital, that's 4 ounces, that has 15 grams of glucose. That's typically enough for a mild hypoglycemia. What happens in the hospital, patient usually gets 2 or 3 dose juices, and then they go from glucose of 65 to 195 in a matter of 1 hour. It's hard to not to overreact and overtreat. Patients do it in outpatient setting all the time, so we cannot, complain about nurses doing it in the hospital. But the key is, try to, for a milder case, is use always oral route. If patient has more severe hypoglycemia or it's unconscious, then one can, clearly give the dextrose. It's a 50%, it's a D50. The problem with dextrose is that, if it does get outside the veins, it can cause necrosis. There have been cases of people needing to have arms amputated, let's say in emergency. They get the dextrose very, it's given very quickly and it gets outside the vein. So it's not, a D50 is not the benign solution. So it needs to be used cautiously and truly for emergency. Glucagon can be given sub-Q or IM, or in the hospital, if patient has IV access, it can be given IV. Glucagon is used for really very severe hypoglycemia, typically if patient is unconscious. So, at home, it's given by, another family member or somebody around the patient, or in the hospital by nurses. And glucagon will, clearly, you get immediate response, really quick. So it's the most potent way to increase the blood glucose. However, patients that are on insulin, actually all patients that are on multiple daily insulin injections, whether they are type 1 or type 2, should have glucagon. Majority of glucagon is injectable, shown here. It comes in this, actually, it's a kind of like an EpiPen. There are different versions of the pen, but it's a glucagon pen. Easy for a family member or somebody else to administer. Recently, in the last year or so, we have a new product called Baqsimi, which is the inhaled glucagon. It does work pretty good, and it's not exactly the same potency as the injectable, but it has advantage that it can be easily given. So if the patient is still conscious and aware, they see they are going to develop significant hypoglycemia, they can use this inhaled glucagon.